Our next presenter is Dr. Tanya Stefko, and she's speaking on HELP. The neurosurgeon wants me to assist in skull-base surgery.
That was the title I was assigned. Oh, I have a question. Do you participate in skull-base surgery with other disciplines, either neurosurgery, ENT, or sometimes plastic surgery? Thumbs up, thumbs down. Oh, you do. Excellent. All right, so this is a talk for you. I'm from the University of Pittsburgh. We have a great skull-base team there. In fact, it's one of the most fun parts of my job. The subtitle for this was How to Speak Neurosurgeon. When I asked my neuro-ophthalmologist and my neurosurgeon, they both immediately said, use small words. So this is a talk that I hope you remember when you're in the middle of a very busy clinic and you get off the phone with the neurosurgeon who just said, hey, I have a case. Is today. Can you help me? And you said yes. After 17 years, I still have no disclosures. So the first thing you want to know is, what are they actually asking you? Because much of the time they're asking you for advice. They want to know, does this have to be done today? Can we do this tomorrow? Can we do it next week? And sometimes they're asking you, does the patient need a shunt? Sometimes they're asking you for a discussion of the approach, and sometimes they're actually asking you for surgical assistance, which is the extra fun part. So if they're asking you about urgency, you basically do your normal exam. However, you add a couple of things. So you make a streamlined neuro exam. Sometimes you're going to do visual fields, sometimes you're not, but you're always going to do color vision, corneal sensation. You're going to assess whether they have any strabismus, and you're going to take a look at the optic nerves. One of the questions you're trying to answer is the poor vision due to something besides brain pathology? Because you really don't want the patient to go to the OR to have pituitary surgery for a cataract. This is the shirt that our residency director wears to the welcome party every year. And if you'll notice, the third from the left actually has only one eye. So if they want a discussion of approach, how are you going to have that? Well, you have to look at the scan. When a neurosurgeon calls you and says, well, there's this on the scan, they're almost always talking about an MRI. But you're not going to be able to do your job without looking at the CT scan, because the orbit's a small place, and you have to see what's still around it, whether there's bony overgrowth, whether there's missing bone, or whether things have invaded the bone. So look at the MRI, which for me, I'm a little less comfortable with an MRI, and then look at the CT together, and it's going to help you with your approach. You have to have a face-to-face or a phone discussion. You cannot do this through the electronic medical record. You lose too much information, and there is too much extraneous information. You need to actually use small words and use few words. Explain it in 50 words or less. Remember, you're the advocate for the eye. You're the advocate for cosmesis. You're going to ask yourself, and you're going to have this discussion with your neurosurgeon and your ENT, does this require more than one approach or more than one surgery? And you're going to ask yourself before you float it, can you add anything with a transorbital approach? Because a lot of times you can. If they're asking for surgical help, remember, you know the anatomy better than they do. All of this is a variant of what you've done in fellowship. An eyebrow craniotomy for a PCOM aneurysm is essentially a brow lift a couple layers deeper and with power tools. Be very specific about your plans and be very clear about your instrument needs, lest you try to sew with 6.0 Vicryl with an 8-inch needle driver. Also understand how this team works. You're going to be there early and you're going to be there late. You open and you close. You're going to take a big break in the middle. And be very clear and very generous about billing, because skull-based procedures are billed by the approach, the definitive procedure, and the closure. So you have to negotiate that with this person. It gets easier as you go along. You have to do a self-review afterwards. Did this patient actually benefit from this, or did we do it because we can? Also, would I work with this surgeon again? It's really important who you're working with. Does this person listen to me and stop when I say, stop touching that? And do I trust this person? Do I trust this person to use the suction the way it was intended? Do I trust them to listen to what I know about the orbit? And then always, the best part for me is, what did I learn? So why are we even talking about this? Look at the skull base. The anterior fossa is where the frontal lobe sits. The middle fossa is where the temporal lobe sits. Both of these are accessible through the orbit. If we look at just the anterior skull base, the parts that we care about are the optic canal, which is guarded by the anterior clinoid, and the superior orbital fissure. Any important neurovascular structure leaves the intracranial area through one of these two openings. What sorts of pathology are we talking about? Well, it's like real estate, location, location, location. It's almost always meningioma. But there's a lot of vascular pathology that we've been using with these. Anything from the PCOM anteriorly, other than an MCA aneurysm, we can often get through an eyebrow approach. Vascular compression syndromes, and then sometimes in well-chosen cases, when you've discussed with the rest of your team, what are the goals of our surgery? Are we just doing this because we can? Malignancy. So the neurosurgeons want to know, how can I minimize retraction on the brain? That's always one of the main thrusts of the surgery. This is really easy for a lesion on the convexity because you take off the bone and it's sitting there staring at you. It's really difficult for skull base or deep lesions. But could we use gravity? Remember, while you're thinking about this, never cross a neurovascular structure. Never work on the other side of it. You have to come in and land on tumor first. So minimizing brain retraction, if we use gravity, we extend the patient, we flex them or we turn the head to one side, and the brain drops away. So gravity is our retractor. The traditional ways of getting to the skull base are the really awful Weber-Ferguson incision, an orbital exenteration, and contrary to what your patients think, you can't put the eye back later, or a bifrontal craniotomy. Bicoronal incisions, who wants to see that? 21st century ways, we can go through the eyebrow, we can go transpalpebral, which is a blepharoplasty incision, we can go transcaruncular, which we all do for medial wall fractures and abscesses, or we can go through the lateral orbit. Your principles are exactly the same. You hide the incisions in a hairline, you minimize your brain retraction, and you never ever cross a neurovascular structure. And for us, there's only one to think about. It's the optic nerve. So again, anterior skull base, from their view, and the two openings that with which we are most concerned. Remember that the eyebrow is a hairline. They abandoned this years ago because they had terrible cosmetic results. But there's a smaller osteotomy, and there are other advantages to it. No scalp necrosis. This lady's had a lot of work done. Where are you going to put your incision that she's not going to get scalp necrosis? Not a lot of good options. So let's move on to a fairly straightforward case. This is a guy who has a carotid terminus aneurysm that he knows needs to be clipped. This is what his head looks like. So we thought maybe we could come through his right eyebrow, and he vastly preferred this because this is his only actual hairline. 3 months later, you can see the scar. 6 months later, you can't. So you know how to do this, and you know how to do it cosmetically. So when we think about eyebrow craniotomies, our two big landmarks are the supraorbital neurovascular bundle, and you can cut it. We cut it all the time. However, you have to cut it after, distal to where it gives blood supply to your pericranial flap, and where the temporal branch of the facial nerve innervates the frontalis. An eyebrow craniotomy gives you this access. You can get the ipsilateral optic nerve superior to it, you can get the chiasm, and you can get the anterior part of the cavernous sinus. The risks are infection, as always, possible brow ptosis, and loss of cilia. This is a case where if you look at the first, before the craniotomy, got a big frontal sinus. If you get into the frontal sinus, we have to use our pericranial flap, and this is where it's going to be important. You can see that going through our craniotomy opening later to wall off that sinus with a vascularized flap. General principles are what Halsted taught us well over 100 years ago. Hemostasis, obliterate dead space, and use meticulous closure. Treat the skin well. It's pretty straightforward surgery. You make an incision, you do a pericranial flap, you make a burr hole, and you do a craniotomy. Then you take a really long break. And then you come back and you do it backwards. Beginning, middle. This is the optic nerve that's going straight up and down in the picture. You can see it's a bit flattened because that's an ectatic segment of the A2 that's coming down and compressing it with every pulsation. End. All right, let's try a more difficult one. 29-year-old guy comes in with headaches. He's got that. How are you going to get there? Well, we're going to go through his left eyebrow. Now, less than 48 hours later, he has this, which is pretty unfortunate. We went in, we looked, and we found a sterile infiltrate. We put the bone back actually 2 weeks later because we've seen this before with bone cement. The reason this picture's in here is because 3 months post-op, the whole tumor's out, and 6 weeks post-op incision 3, it's hard to tell which side we worked on. The brow is very forgiving. So let's try a transblepharoplasty one. This is an incision we're all familiar with. This reaches a bit higher and a bit more posteriorly. This lady came in with headaches. She has very thin eyebrows, and she very much wanted a blepharoplasty approach rather than an eyebrow approach. This is an intraosseous meningioma along the roof of the orbit, 1 year post-op, no recurrence, and this is what she looks like, 1 year post-op. We went through her eyelid crease, and she's pretty happy. Let's do a transcaruncular one. We can reach much more anterior than an expanded endonasal approach. We avoid the lacrimal system, and we avoid the trochlea. We have a 13-year-old who fell off his dirt bike 18 months ago and has had at least 2 episodes of bacterial meningitis. He really doesn't care about that. He thinks this is super annoying that he has to come from Kentucky to Pennsylvania to get this surgery. However, he does care that his eye is too far back. They did a really nice job of reducing his zygoma, but they didn't fix his medial wall, as you can see from this. And you can see the area where he's got a leak into his frontal sinus. So we offered him an EEA in order to get a vascularized flap and a transcaruncular approach. We repaired his medial wall at the same time with MedPore Titan barrier, and you can see in his post-op scan, the MedPore, at least you can see the MedPores in the right place. 1 year post-op, he just needs a ptosis repair. So what if we go through the lateral canthus? Now we can reach back farther and more lateral, and we can get to the cavernous sinus, the middle fossa, and sometimes the posterior fossa. The lateral canthus gives us the cavernous sinus and the temporal lobe, as well as a little bit of exposure to the carotid, but not much. This lady came in with seizures. Now, the traditional approach for this would be a terional. However, you can get that out through this. These are other patients that are 1 year post-op. The lady on the top had a right lateral canthus, and the lady on the bottom had a left lateral canthus. And yes, I'm not super happy with how that folds over a little bit. But this lady I just saw this week is 5 years out, and she's still pretty happy. How far could we go? Sometimes the tumor creates a corridor for us. How about the posterior fossa? This is a 38-year-old Jehovah's Witness who has increasing pain. She's up to 2,400 milligrams of Neurontin a day, and she's still not under control. Pretty straightforward schwannoma, but you know it's going to bleed. You also know that you can't transfuse her. What if we do this through the lateral canthus? And here's our pointer in the posterior fossa when we've taken all the tumor out. You put fat grafting in, you close up, and a week later, she looks pretty good. So how about combined approaches? Combined approaches are how you take these 6 base flavors and get to all of these over here. And I'd like to point out that the most important base flavor is chocolate. Has no impact whatsoever on our surgical choice. It's just important in my life. So a combined approach, you can get all the way over to the contralateral optic nerve. You can get all the way, even lateral to this, out to the tip of the temporal lobe. We have a 48-year-old guy who's in IT. He works for our company, and he comes in because they found an incidentaloma. And when you look at his exam, he's got a very subtle afferent pupillary defect, and all he has on his OCT is a little bit of ganglion cell loss on that side. But he's 48. You know this is going to get bigger, and it's going to get harder to take out the bigger it is. Now also look that you see that it's on both sides of the optic nerve. It crosses the midline, so you can't get this with just an eyebrow approach. He's not up for a craniotomy. His immediate post-op scans shows a lot of dural reaction but complete resection of the tumor. And we did an EEA and an eyebrow approach on his left, and here he is 3 months out, doing reasonably well. So you can do this. You've already learned these approaches. You go to the lab with a neurosurgeon, you do a little bit of work, and you can do these, and they're a lot of fun. And this picture's in here to remind you that it's important to have fun with your work. We made birds the other day out of the unused aneurysm clips. And the clouds are out of Surgifoam. This was after the patient was closed. So, thank you very much.